Hello, everyone. My name is Elizabeth Kabuthi. I am a medical social development officer and a certified child life specialist at the Moi Teaching and Referral Hospital in Eldoret, Kenya. I feel honored to be the moderator for today's call, where we are going to address factors that create financial barriers to cancer care from the patient and program level. So before we begin the session, we are going to share the house rules. We are all reminded to be on mute unless you wish to speak. And if possible, if your bandwidth allows it, please put on your camera so that you can see your lovely faces. This aids in interaction and it feels warm. This session is going to be recorded for future reference. And if you wish to share your experience, feel free to raise your hand or you can use the chat box at any time. So this session is divided into three. We are going to have a didactic lecture from Dr. Kunuz Abdullah from Ethiopia, followed by a case presentation by Dr. Robai Gakunga from Nairobi, Kenya. And without further ado, let's dive in and begin the session with Dr. Kunuz. Who is Dr. Kunuz Abdullah? He is a public health professional with over 20 years of experience in health system policy research, program development, and strategic planning. His career is built on cumulative experience from grassroots health program implementation at district level to national and international health program design, strategic leadership, and management. Currently, he is a senior advisor to the Minister of Health of the Federal Ministry of Health of Ethiopia on non-communicable diseases and cancer. A warm welcome to you, Dr. Kunuz.
Thank you very much, Elizabeth, and also all other colleagues for the nice introduction. And I was listening to it like afresh, and it was very good. It's well captured. Thank you. So I'll go on my presentation. I think I have about 50 minutes, right? Yeah. Okay. So would you please run the screen so that yeah. So I will try to go through the following content, and I will give you a bit of background on the country, Ethiopia, and also the health insurance system in the country, and how our program is supporting, the ministry is supporting the cancer medicine through the program, what we call the subsidy program, and also the public procurement service list, which also includes the cancer program. So I just want to go through that one also. And also the logistic issues. I'll talk about how the cancer commodities are getting into the country and what kind of process we are going through. So these are my outline, and then I'll go directly into the presentations right now. So on my on the background, Ethiopia is one of the countries in the eastern part of Africa. We are not actually in the East African bloc, but it is in the Horn of Africa. And usually when you get information about the East African community, Ethiopia is not a member of it, but we are quite located in the Horn of the continent. And our population is the second populous country in Africa after Nigeria, with a population of over 120 million. And from the Globocan database, we know that Ethiopia gets like a new annual new cancer incidence of around 77,000, and this includes all types of cancer. And of course, breast cancer is the leading cancer in the country, followed by cervical cancer. And if we look at the data from the NCDs in general, cancer accounts for close to 10% of all deaths from the NCDs. And the Ethiopian public health structure is We have a three-tier system where we have the primary level healthcare, which constitutes health post health centers and primary hospital. And the secondary level, we have general hospitals, and we have specialized tertiary care structure also on the top. And we have a peculiar arrangement of what we call the only female health extension workers who are based in the community. And currently, we have over 40,000 female health workers who are basically doing the health communication business in the community, and they run from house to house and they deliver messages right to the household level. And like any other African countries, the majority of cancer cases are all detected at a very late stage, and predominantly this is due to lack of information and also lack of the cancer service providing facilities. So we have quite limited access, and our currently our total treatment coverage is not more than 15% in general. So we don't treat over 80% of our patients. So you can imagine where these patients are going and how wide the gap is in terms of care. Next slide, please. Yeah. So the mechanisms we have to address issues related to costing the cancer services in the country, we have different modalities of care. The first one is the health insurance system, which is very new in Ethiopia. The other ones are we have also the subsidy program, which I will come onto it later on. And so our health account tells us that more than 30% of our care for NCDs in general are out of pocket. So this is a big chunk, and the other 30% is coming from the government. The rest is coming from donor and partner support. So our out-of-pocket coverage is big, and so which means that patients usually cover their services from their pocket. Our health insurance system is new in Ethiopia, is still in the formative stage. And we have what we call community-based health insurance, and we are also working toward the social health insurance system. And what we know at this point is the cancer care commodities are all included in the health insurance system for the country. However, due to high cost of cancer medicine, the insurance system is not currently practically providing care for cancer patients, which means that even if patients are covered by the insurance system, when they go to facilities, because of the high premium and the availability also factor, usually they tend to go out and buy from private outlets. So the health insurance system is theoretically there, but in practical terms, it is not really supporting the patient with cancer. However, we also know that the health insurance system really covers the majority of districts in the country. Like close to 90% of all districts are covered by the insurance system. And usually the premium comes from membership contributions and the premium contributions. So when you look at this, the health insurance system, it is a promising arrangement, but there is a great degree of work that we need to do to make sure that the insurance system is really functional and giving service to patients. I know there are very good experiences from other African countries, including from Kenya, where the insurance system is really functional. So I hope during the discussion time we'll be able to learn from other countries in terms of how to make the insurance system more protective to cancer patients. Next, please. So in addition to the insurance system, the government from 2014, recognizing the burden of or the catastrophic cost of cancer medicine on patients, we've come up with the program called the subsidy program. The subsidy program means that the government covers 50% of the drug cost to patients. So the other 50% usually comes from patients. So this, even if the 50% coverage is now in practice, still the 50% is quite a huge sum of money that's falling on cancer patients. So it's not like it's a kind of a relative reduction of the cost, but it's not an absolute reduction of the cost to create better access. So I think we need to what we learned from the subsidy program is that we need to work on an absolute reduction of cancer medicine cost at a global level. We need to influence that. Otherwise, if the cancer medicine comes at very high cost, even if we put 50% into it, still the remaining balance is quite huge. So I think the global community need to promote the arrangement where the absolute cost of cancer medicine should come down. I think we need to follow the model of like HIV AIDS program where the global community is putting a lot of resources into it, and patients are getting the real free medicine at their need. So I think that is not happening for cancer community in general. It is true for I think this is true across the world. So I think there are quite substantial movements around the world. For instance, very recently we attended the so-called the access to pediatric cancer program. There was a meeting that was held recently in Uganda, I think a couple of months, 2 months, 3 months ago, where some global institutions like WHO, UNICEF were collaborating with some pioneering hospital like the St. Jude Hospital, where they are pledging 200,000 US dollar, no, 200 US dollar, 200 million, sorry, US dollar in support of pediatric patients over the coming 6 years, and aiming at treating 120,000 children with cancer. So I think that kind of approach is I believe is taking us to the global collaboration of reducing the drug cost and also improving availability and affordability of cancer medicine. So this kind of initiative is very promising, and we need to push. So African countries are now applying for this resource, and we recently had a call with St. Jude Hospital where Uganda, Kenya, and other countries have participated in that call, which basically told us that the countries need to demonstrate their efforts in pediatric cancer care to be able to access this resource. So I will come to it in the discussion later on. Next, please. So we have what we call the public procurement service list. So in Ethiopia, we have worked in adopting the WHO essential list of medicine for cancer commodities. So recent I mean very not very recently, but over the last couple of years, 4 or 5 years, we have managed to pick on 53 prominent, 51 prominent, and usually required list of cancer medicine. This is in consultation with oncologists and the providers to make sure that we are picking on the most important medicines for pediatric cancer care. So 51 have been selected, which is in conformity with the essential medicine list of WHO. So we are working on this. The reason why we are picking on this is because there is issues related to uh, availability and also the logistics issues, which for most companies they are not interested in providing low volume uh, commodities, and they are not really motivated to produce and the package and send back to countries where they really need very small amount of very small volume of medicine. So this procurement list is helping us to focus on the most important of cancer medicine. And we are also thinking of, like, for instance, in the future, thinking of a pooled procurement system where maybe few countries come together, like in East African country or even sub-Saharan African countries, where they will be able to procure in volume and better negotiate on the global cost of drugs. So we are also working on that kind of arrangement. So having a public procurement list of essential medicine would help us to also look for market shaping. I think some partners are very active in this, like for example, Clinton Health Access Initiative. They are really interested in working with countries in sub-Saharan Africa to negotiate with pharmaceuticals for better offer of costs. So I think some selected items have been negotiated on, and but the level of uptake by countries is quite variable, and some countries have used that opportunity, but some countries have not used it, and they went to business as usual kind of thing, and they never accessed those negotiated prices at a coordinated manner. So that is also something that we need to consider during our discussion. Next. So the other thing is a bit of internal issue, but I just wanted to share it with you. The challenge we are having with cancer medicine in general, in term, not only the cost, but also the custom and the logistic issues involved in terms of transport and the local clearance and all that. And usually the cancer medicine, they come up with a very short uh, shelf life. So unless countries have a very efficient and fast tracking system of clearance at custom, they will be they can very easily lose or waste drugs. And we have had this experience in my country where quite a good volume of our expensive cancer medicine were deemed to expire. So I think we need to advocate at higher level for recognition of the special needs of cancer commodities and also fast tracking cancer drugs at custom. I think this applies to most countries where um, the custom business and the technical business at the ministry level, Ministry of Health level, usually they are not really running well together. So I think we need to also discuss this and probably share how some countries have better performed on their custom related issues. And this is not only for, by the way, not only for cancer medicine, but also for other cancer treatment logistics. For this example, if issues related to radiation treatment or reagents for diagnostics, usually they expire at the custom door. So I think we need to also discuss this because the total, the sum effect is that it's going to affect the individual cost of patients. And for instance, where reagents expire, you have to send patients out of the country sometimes and exposing them to high cost of care. So I think it is very important thing that we have to consider. The other thing which I would like to raise as an issue is the indirect cost of care for cancer patients is never recognized. For instance, we always talk about drugs and medicine, but the indirect cost, like related to transport, related to hospice services, where patients have to stay accommodations and costs of accompanying caretakers, and all these are very actually they dominate the big, they take the big portion of cancer care. So I think we have to look at it at very holistically. Where does the major chunk of cancer cost goes, and which one is falling on patients? We have quite handful uh, partners who are coming and supporting patients in providing them accommodation, transport, and even some diagnostic and the medicine support. So I think I hope the discussion will also shed some light on this. I'm trying to just pick this high level issue so that we can make we can really dissect and see where the cost is coming from and how it hits our patients. So thank you very much. I think I have to stop here, and then if there are questions, I'll come back to it. Thank you very much.
Thank you, Dr. Kunuz. Thank you for that insightful presentation. And thank you once again for helping us recognize the amazing efforts by your government to reduce the financial burden on patients accessing cancer care. What has really struck me is the idea of community-based health insurance. Maybe it's something that we would all love to hear more about in the Q&A question session. Thank you, Dr. Kunuz. So I'm going to introduce Dr. Robai Gakunga, who is going to share with us her case presentation. Who is Dr. Robai Gakunga? She is a population health research scientist based in Nairobi, Kenya, working for the last 15 years as a consultant and in collaboration with many leading organizations at the national, regional, and international level. Robai was the in-country consultant for the US CDC study on the economic assessment of resources required to report cancer registry data in low and middle income countries. She recently led the costing of cancer registration for Tanzania's Ministry of Health in collaboration with Vital Strategies and the Africa Cancer Registries Network, and is similarly providing technical support on the economic evaluation of cancer registration to the Sri Lanka Ministry of Health in collaboration with Vital Strategies. Robai has worked with Dr. Subramanian of RTI International on many costing studies in Kenya in collaboration with the Kenya Medical Research Institute, Kenya Cancer Association, and Kenya Hospices and Palliative Care Association, and has published in many joint peer-reviewed journals. She is currently co-investigator and country lead of the NCI US-funded implementation study, C3Link, which is an integrated community clinic model of optimized implementation strategies to increase early detection of breast and cervical cancers in selected counties in Kenya. Her research focus is to use data science techniques and big data to understand population health dynamics and to evaluate population health interventions. Welcome, Dr. Robai.
Thank you very much, Elizabeth, for the kind introduction. And good afternoon, everybody. And good morning to Mishka. Thank you so much for allowing me this time to share my experiences. And it will basically be related to research because that's where I've been operating for most of the time. So I'm just going to look at some of the published work on costing of cancer care and basically in Africa, basically with reference to Africa. Okay. Good. Can you see my screen?
Yes, perfect.
Thank you. So just as a background, there's a study that we did here in Kenya just to understand the barriers to cancer care in Kenya, and some of the questions that we asked the participants who were women aged 20 to 60 years old. We asked them what might deter them from going to see a doctor. And you can see that cost was the highest at 46.3%, and then transportation barriers, which was 23.3%. And you can see these two high buckets of costs are basically associated with, these two are basically associated with cost, because even when it comes to transport, some cost element comes into it. So let me just give an overview of the type of costs. And Dr. Kunos mentioned this in his presentation, where he said that different types of costs that are incurred when individuals are seeking care, not only cancer care, but other medical care that they'd be looking for. So we have direct costs, and then we also have indirect costs or intangible costs. Dr. Kunos mentioned the direct medical costs, which we normally talk about, that is inpatient, outpatient, procedures, tests, and drugs. And then we also have the direct non-medical costs, which our respondents talked about, transport. We also talk about home help. Sometimes the patients need some help at home, and so some people have to be even employed to take care of them, or some people have to stop working so that they can take care of their relatives or friends who are sick at home. And then when it comes to the indirect costs, we are talking about sick leave, that was led by Dr. Subramanian, and I was part of it. We were costing based on the patient payments. So it does not include the other indirect costs, like when they are not working, or their home care, or like transportation. No, this was just the direct payments that the patients had to make to their healthcare facility, or to buy medicines and things like that. So you realize that for example, breast cancer screening in the public health facilities, which was just the clinical breast exam, you can see that they were spending about $2 in the public facilities and $18 in the private facilities. Now, just recently, actually yesterday when I was in the field, just looking at with the study that Elizabeth mentioned, we find that there are some facilities that may offer VIA-VILI, and that would cost about $3. $1 for registration and $2 for consultation for the VIA to be done. Now, even that amount, $3, women are not able to show up for screening because, you know, basically they are well, they are fine, they are not sick. So how they would just leave their duties and go to a facility, pay up 300 shillings, that is Kenya shillings, about $2 to $3, just to be able to do this test. They may not quite understand that, okay, in the long run, it could be helpful, but for the immediate term, they really need those $3 for other things. So there's a lot of balance there, and you find that many women will not show up for screening. And true, our screening uptake is very low, and that's why we want to do this implementation science study to be able to identify exactly what makes women not go for screening. And if it is cost, we will have an evidence base to justify even advocacy for further funding, and also for treatment, diagnosis, and whatever follows on. So these are the figures that we got during that study. And as I said, it's from patient payment perspective. So, so basically what we see here is that even when we look at these figures, like for example, if you are looking at breast cancer treatment, you find that stage 1 and 2 are quite expensive, but when we get to stage 3, the curative approach, it is even more expensive. And then when we're looking at the palliative care approach, it goes somehow lower. So yes, the effort is to prevent and prevent and prevent. Screening so that if the cancer is diagnosed early, detected early, and managed early, then we can be able to avoid the higher costs of care. So I just went through some literature to find out what else other researchers have found out about individual barriers and the possible solutions that they came up with. So as we mentioned, transport, accommodation, patients from rural areas often face additional expenses related to traveling to the urban centers for cancer treatment. So the possible solution was to decentralize cancer treatment centers so that we establish cancer centers in different regions so that any patient can be able to access them without having to travel for long distances and also maybe incur more costs when they're seeking accommodation in those places. So in Kenya, this has happened quite a bit. There are centers of excellence, cancer treatment centers that are coming up, and this will be quite helpful. We have radiotherapy machines being placed in different places so that patients can easily access that kind of treatment. So definitely the costs to the patients will go lower. And then we are looking at socioeconomic status and financial barriers for individual patients and their families. So we need to increase the role of patient navigation so that even they can be able to provide financial guidance to patients. You can, for example, be able to find cheaper services in one facility, and so to guide these patients to be able to access those services in a more cost-effective manner, and that will save some cents that can be used in other areas during their treatment. Then we also need better communication by caregivers about diagnosis and financial implications to the patients so that they can avoid some sort of mistrust that comes up between patients and caregivers if they are not quite open about, the different types of treatment that they are giving and the cost implications, so that patients are not just being given the treatment and they do not really understand the cost implication. And I've had a chance to meet with some survivors during my research work, and they say that, when they went to see their doctors at the first instance, they were told to go for some tests. And in their mind, they knew that they would just go back to their doctors and get a prescription and go home and get well. But it turned out to be a really long process. So even after spending all the money that they had on diagnostics, now they didn't have money to carry on with the treatment. So all this needs to be disclosed at the onset. Then lack of financial means to avoid cancer treatment, including diagnostic tests and surgeries and chemotherapy and radiotherapy. Again, we keep on emphasizing the need to enroll on healthcare insurance schemes. Like Dr. Kun has mentioned, in Kenya, we have the National Health Insurance Fund, which has been very helpful because they have an oncology benefits package. There are some challenges, yes, but people have really benefited from this. Then lack of insurance, and the individual barriers can also be lack of insurance and insurance covering less than they expected. Of course, they have to pay up some premium for even the NHIF, and some individuals are actually not able to afford this. So the idea for the government is to strengthen and expand the health insurance coverage, and maybe also be able to pay for the really, really low income earners so that they can just, be able to enjoy the insurance as well. Then we have the issues of late stage diagnosis. We know that the curative approach demands the curative approach for higher stages of disease will cost more. So we need to enhance awareness and build capacity for cost evaluation, not breast, sorry, and then focus on downsizing of symptoms or symptomatic disease. And then we look at screening as well. Screening that will prevent a lot of late stage detection and diagnosis. Then when we look at the system barriers, cancer drugs can be expensive, especially newer targeted therapies and immunotherapies, and making them affordable for many patients in Africa. So again, Dr. Kunuz mentioned that there is a chance for us to be able to negotiate with pharmaceutical companies to reduce the prices of cancer drugs, and so that we can be able to ensure affordability. And also I liked what you mentioned about countries coming together so that medicines can be bought in bulk, and that will help us with economies of scale. There'll be a win-win situation from the pharmaceutical companies and those who will be buying those products. And then also another solution that was mentioned is production of generic drugs, and this can significantly reduce costs. Cancer diagnostics can be expensive, and some solutions are public-private partnerships. As I went out in the field, maybe like a week ago, there's a county that has this kind of arrangement with the private facilities in their county, so that patients can be able to access diagnostic services at a reduced cost. Then another system barrier is late-stage diagnosis, and we need to enhance community-level interventions, awareness, education, behavior change, so that we can increase participation in screening, and hence we can get earlier detection to minimize costs of late-stage treatments. Then there are issues of visiting more than 4 different healthcare facilities before a diagnosis is confirmed. This happens quite a lot, and so we need a lot of training for personnel, increasing, getting better equipment, infrastructural capacity on specific screening and early detection and diagnostic techniques. So we need to improve on this. And also the way we keep our records. These records, if they are kept well, sometimes you find that a patient may go to some place, and when they're given their report, they lose it somehow, or when they are going for the next visit, they do not have it, and they do not even know that they have done that test before, so it is recommended by their healthcare provider, and they keep on repeating the same test, when indeed, if they had the report for their previous test, they could have just used that one and not having to repeat. So some of those repeats of diagnostic tests end up making this cost go high. Then again, limited health insurance coverage. We've talked about strengthening and expanding health insurance coverage. And then when it comes to cost of screening procedures, so we look at integrating cancer screening within the national HIV programs and even MCH, so that
Have we lost Rabai? Hello, Rabai. I think we have lost Rabai, so maybe we can fill in for her before she comes back. Dr. Kunuz, CBHI, it's impressive. Can you share with us what that means, and maybe we can have you share with us what that is all about in Ethiopia? Thank you. Hello, Dr. Kunuz?
I'm there.
Okay, thank you.
I think we've lost Rabbi.
Hello. Okay, so I will go to the chat box and let us share what is on the chat box. Oh my gosh, accept cookie.
Elizabeth, are you having some audio issues yourself?
Hello? Hello.
Hi, Elizabeth, we
My
can hear you.
internet is a bit shaky. Apology for that.
No problem, we can hear you. Elizabeth, can you hear us?
Mishka.
Elizabeth, I can go ahead and facilitate for a moment. So Elizabeth actually had asked Kanu's question to you. Oh, wait, I see Robai is coming back. We can see if she can continue her presentation. One moment. Let's just wait for Robai to reconnect. Thank you, everybody, for your patience. Hi, Robai, welcome back.
I'm sorry about that, Mishka and
Oh, no
everybody.
problem.
Yeah,
No
I'm
problem.
sorry about that. Yes, so I was just talking about the limited research that we have in sub-Saharan Africa. And so I was just looking at international collaboration, and it just doesn't have to be financial. We can look at technical support and exchange ideas on how to alleviate the cost burden in our countries. Then we need to be able to support research, especially economic evaluation. When we have different types of interventions, which one is more cost effective than the other? And it's very country dependent. So for example, some countries may have different budgets for healthcare. They have different cultures. So their willingness to pay is very unique to their situations. So we can actually do research that is local research so that we can be able to use this as researchers and be able to communicate this to our policymakers so that they can make informed decisions on what kind of interventions that will be cost effective for our populations. Okay, so I'm just trying to move to the next slide. Are you still seeing the slide?
Well, I had to start sharing from this end. Since we lost you, we lost your slides. Do you want me to stop sharing and you pick up again?
Okay, fine. All right.
Okay, I'll
I'm
stop.
just about to finish this. So sorry, please,
No,
guys.
no problem. Go ahead and you can share from your side now.
Okay. So are you able to see this?
No, we're not seeing your slides right now.
Okay, let me get that.
All right, you're back.
Okay, that's
Perfect.
fine. All right, thank you. Thank you. So just about 2 more slides and I'll be done. So public health needs are enormous. There are many. So we need to be able to make use of the limited resources by minimizing costs and maximizing outcomes so that we can even be able to sustain this for longer periods. And we know that resource allocation choices must be made. And these choices will often carry difficult trade-offs that needs to be made. And we need evidence to be able to make informed preferences. So the way is by carrying out economic evaluations to demonstrate the value provided from the research, that is the return on investment, and to be able to evaluate the alternative health interventions that are available so that we can be able to understand the cost effectiveness. And as researchers, if we can go into this and be able to get all this evidence-based information and provide it to our policymakers, then we will be able to manage costs more effectively. Then we also have the implementation process, which can be optimized so that we can reduce costs. Implementing some of these interventions. Sometimes you find that intervention even takes so much more, just the implementation part of it, it costs so much. So we need to be able to increase our effectiveness in these areas. So for example, in cost effectiveness analysis, and it's okay, like cost effectiveness analysis is it's actually a valuable tool that can be used, and it compares incremental cost to the incremental benefit that can be gained. And this is used to derive the cost effectiveness ratio. The cost effectiveness ratio is what we will use together with the willingness to pay, the budget allocated for health in different countries. And this can be used to be able to determine which intervention we can prioritize over the others. And this, as I said, is very specific to different countries or different localities. You must be able to determine the willingness to pay, to be able to determine the cost effectiveness of different intervention. One intervention working in one kind of jurisdiction may not necessarily work in another jurisdiction. So we need a lot of research, local research. And then we, as researchers, we also need to use methodologies that are also cost effective, and we will be able to get similar results. Like for example, using interrupted time series analysis. If we have data that has already been collected, for example, we have the Nairobi Cancer Registry, which has very good data, and Nairobi Cancer Registry data has actually been used, included in the Cancer in 5 Continents. So this means that it is good data. It is quality data that can be used for different kind of analysis. In this study, I was looking at time to treatment initiation of cancer in Nairobi County. And I was able to determine the time to treatment initiation by just calculating the difference between the incidence date and the time that the treatment began. And I used data from 2010 to 2020. And I was trying to evaluate the impact of the introduction of the NHIF Oncology Benefits Package to time to cancer treatment initiation in Kenya. And you can see the blue curve, the way it goes. So time to cancer treatment initiation was taking very long at around 2010, and it has continued to reduce. It continued to reduce into 2012 and 2014. And that vertical line, the gray vertical line there, shows the intervention time. That is 2015 April. That is when the intervention happened. And you can see that it kind of leveled off, but increased around 2018. So the findings here are that during the analysis where we did, I did some modeling on this data, the time to cancer treatment initiation did not necessarily increase or decrease. It did not change at all during the introduction of the NHIF Oncology Benefits Package. But that does not mean that the NHIF was not helpful. It could have been helpful in that after the initiation of the treatment, the treatment could be sustained because of the Oncology Benefits Package. And what this means is that Nairobians are quite resilient. They will look for ways of finding finances to start their treatment. But whether they maintain it or not, or complete it, is another story. So there was no change at all in time to cancer treatment initiation. But then maybe I can just they were consistent with others that were done, and that was because of healthcare workers' strikes. So when healthcare workers went on strike, the time to cancer treatment initiation in Nairobi County went up, and you can imagine the effect that that had on the outcomes, the final outcomes of these patients at that time. So thank you very much. And I've taken quite a lot of your time and the disconnections and all. Sorry about that, but here are some suggested readings that you could go through. Thank you very much. And back to you, Elizabeth.
Thank you, Dr. Robai. For sure, your years of research has enabled us to gain insight into your incredible work. And I admire the depth of understanding of the subject matter, quite commendable. In both discussions, I've noted that Dr. Robai and Dr. Kunuz have spoken about advocacy on the side of the government, advocacy in terms of reduction in pharmaceuticals, and that is quite commendable. What has touched me most in Dr. Robai's presentation was the fact that when you look at the possible solution to system barrier, there was one comment, fear of wasting the doctor's time. Those are really things that we may assume are so petty, but for sure, this is really huge. And it has really touched my heart because maybe in one way or another, as healthcare providers, we have displayed a reason for our patients to feel this way. And so thank you, Dr. Robai, for bringing this up. So I'm going to open the Q&A session. And I'm looking at the chat box, and I want to appreciate all that you have written on the chat box, beginning with John Black and the fact that you're talking about the importance of financial counseling, financial navigation, which is really crucial and important for us to start these discussions well in advance before the patients begin their treatment. And in the group, I can see Dr. Zipporah Ali. She's spoken about improving or implementing EMRS in keeping patients' records in a systematic manner. That is quite good because it will ensure that these records can be followed up even for years, and we are able to keep up with cancer registries. Maybe I will ask Dr. Zipporah to give us a summary of the Cancer Control Strategy 2023 to 2028 when we have time after we finish up with the discussions. Then there is also a comment by Koima. The non-medical financial barriers play a big role in accessing care. Patients who are covered by health insurance can miss fare. We have seen that in both presentations by Kunuz and Robai, that these indirect costs are really huge for patients, and that is why we have big numbers in loss to follow up. Digital health information, again, very important to have EMRS. And of course, telemedicine is also quite important. And Moses is also asking about organizations that support to register oncology-related cases. And I see Beryl and Tom from Faraja Cancer Trust and Hope for Cancer Kids are in the group. And you can also share what it is that you do as far as registration is concerned. Maculin is also discussing about simple communication materials, infographics on stages, steps to cancer diagnosis and treatment can be quite helpful. This is true. And I don't know, maybe to Dr. Zipporah Ali, Dr. Zipporah Ali.
Okay, you put me on the spot.
Sorry.
Yeah, I think we would probably like maybe one day get Dr. Nyangasi and her team to talk about the strategy in full.
Mm-hmm.
But maybe I can just, in a few words, just say that we did launch our strategy, National Cancer Control Strategy on last week. It was from Thursday to Friday. It's a strategy for 2023-2027. And the reason why it took 2 days to launch is because pre-launch, we had quite a number of sessions on different things, cervical cancer, breast cancer, health systems, and improving cancer care and many other things. But the actual launch of the strategy took part on the the second day on the Friday, it was launched by the Principal Secretary of the Ministry of Health, and we had quite a number of representatives from the counties. And so I think our strategy is building up on the former strategy. We have, as a country, we've come a long way in actually achieving what we had put in the former strategy. Of course, not everything, mainly because of the fact that we do not have enough resources, whether financial resources or human resources. And so it's still a work in progress. And so we are building, this strategy is actually mostly building up on the former strategy and had a number of pillars. I think the vision was a cancer-free Kenya. I can't remember very well, but it's really looking at introducing the incidence of cancers in Kenya and improving cancer care, not just focusing on, it's not just focusing on care this time. There's more focus on actually primary prevention on cancer. And again, it has also included more focus on the other aspects of cancer, of oncology, that is the psychosocial issues as well, and the emotional issues, and not just finishing with the actual treatment of the cancer. So yes, we are, I think we will need a whole session on that to be able to talk about the whole strategy. But I'll just maybe mention that there are a number of pillars. I don't know them. I can't know if I remember all of them by head. But there's a pillar on cancer prevention and early detection. There's a pillar on a pillar on improve. What is it? Okay, what was on treatment care, palliative care, and supportive care. There's a pillar on also things like imaging, pathology, and laboratory medicines. There's a pillar on human resource and other resources. There's also something on advocacy. Well, I'm mixing them up now. So there's, like I said earlier on, there's prevention, there's cancer treatment, palliative care, and survivorship. There's also cancer surveillance. That is also very important for us to understand where we are coming from, where we are heading. There's a pillar on advocacy, partnerships, coordination, and financing as well, I think. And yeah, I might have mixed them up and not mentioned all of them, but it's quite more, because I think there was something that we introduced in this one. We introduced strategic information registration and surveillance research as well. And formerly we just had surveillance and research, but now we're introducing other aspects of cancer that we think are very important in having a comprehensive strategy. So we're hoping that this strategy will, it was also costed. We're hoping that this strategy will be able to give us a way forward in how we are going to handle the burden of cancer in the country, from prevention to diagnosis, to treatment, palliation, rehabilitation, survivorship, and beyond that. So that's all I'll say. But like I said, I think we will need a whole session where we can have the team now, give us more insights, and especially not just this strategic plan, but also the way forward. What are we planning to do, not just as the government, but even as a stakeholder? What is our role in ensuring this strategy is successful? Because we also have a role to play, whether we are civil society or even patients, because if patients also don't add up to treatment and the rest, then we have all those problems that come with that. So it's really going to be an inclusive strategy for everybody to be involved. Thank you.
Thank you, Dr. Zippy, for always being up to the task. Both presentations today have really talked about cancer advocacy, coordination, partnerships, and financing. And I'm really glad that you are here with us this evening to give us an insight on that. So John Black.
Yes, good afternoon, everyone. Good morning, Mishka, and whoever is on the west side. Thanks to the presenters. I think this is a very good discussion. I wanted to ask your thoughts about things that are maybe what the individual can do about these issues, because there's been a lot of discussion about what the governments can do, things that are sort of high level and they take years, for policies to be passed and strategic plans, and many times they're not implemented because they're like, very high level. And so I wonder what, an individual, patient, or people close to them can do. And there are some examples. And I remember when we were doing preparation for this, I was talking about community-based insurance mechanisms And I know that now there is a bit of efforts to formalize those, and sometimes that makes it all very complicated because then you need to have a constitution, and then you need to have like a expert finance people to make sure everything is done correctly. But there were, for example, in Uganda and specifically in Buganda, these set things for social protection. I think we used to call them monomukabi. I don't know if there's anyone from Uganda here who knows this, but there were, mechanisms in society where literally monomukabi means a friend in need. and that was an arrangement where if someone would be sick, the community would, the neighbors, the extended family would come and they would bring them food and they would take them to hospital, they would contribute. And the thing with this is that it has a lot of, of course, it requires solidarity from the community and the family, and now we have increasing individualism, in many African societies, which wasn't there. But it also you have flexibility in what you can do. So when you have, for example, when you have insurances, they might say, "Oh, we don't cover transport, or we only cover medicines, or we don't cover, operations that are beyond this much." But with these informal arrangements, you would have, there is no limit, there's flexibility. So I wanted to hear your thoughts about this from both of the presenters, and if there has been any such efforts, or if we should be pushing for these things. Over.
Thank you. Dr. Robai, Dr. Kunos.
Yes, I think, the comments are very valid, and we accept all. And I think, the issues, I've missed some of what my friend has said, but I want to add one perspective to our discussion. Like, we're talking about cost to patients, and there is always a challenge in terms of what kind of cost we would reasonably allow the patients to go through. So I want to raise the issue of ethical considerations in, for example, treating quite terminal patients where they spend everything in search of cure, and then finally they will leave families back with, like usually going into destitution, selling their home, selling their assets and everything, and then eventually we know for sure that that patient is not going to make. So I know it is very challenging, but I think the issue of how far we go in terms of treatment is always at a crossroad. So I just wanted to get the view of other colleagues on this, and I thought it is something that we are facing day and night in my country, for instance, where patients are desperately going for treatment without any really, promising outcomes. Thank you.
Thank you, Dr. Kunos. I see a hand raised by Tomo Ching. Please share.
Evening, everyone. Hi, Elizabeth.
Hello.
So I wanted to respond to John's black question of how individuals can get involved in supporting cancer management or cancer treatment of the burden itself. And from my experience, I've been in the patient navigation program at Kenyatta National Hospital since 2017. And collectively, we've intervened in over 16,000 cases in the past 5 years. And what we noted was that our main asset as service providers is to educate and provide awareness. I'll give you an example of our realization when we noticed that despite NHIF paying for like 75–80% of the treatment costs, you'll find that in a household, in Kenyan households, 3 in every 5 households that you interact with, none of them have NHIF. So we made NHIF our top priority. And then we just learned to work up the system whereby now we say for married couples, we'll advise both individual spouses to get NHIF insurance. So what that happens is that with one insurance, you can get cover up to 75% in relation to diagnostic and treatment costs. But you find that this still is not enough for those that are not, do not have regular income. So when your spouse has an insurance, you are included into that insurance. Now you have access to 2 covers within a financial year. The benefit of this is that with radiotherapy, for example, NHF only covers 20 sessions. But for patients with head and neck cancers, you'll find that in a given financial year, they'll be given like over 33 sessions of radiotherapy. So that's an extra 13 sessions that you have to pay out of pocket. What we do is that if this person is married and the spouse has NHIF, we encourage them to use the spouse's NHIF. So you'll find that in a given time period, they're able to receive treatment without paying for a single cent. Other contribution will be just to encourage people to, donate anonymously and be inclusive in these community outreach or awareness programs, just to learn some of the experiences or some of the gaps we have in our society. And during this past 5 years, the services we provide, all the services we have received, especially when mobilizing resources, you find that a significant number, about 30%, have come from individual donors. They either contribute material, they either contribute money, they either, technical assistance, or just time and comfort. So in that relation, you'll find that in that situation, you'll find that if we combine all these efforts, the patient is supported through treatment and also post-treatment.
Thank you, Tom, for sharing.
Thanks Tom, for the insights. It really helps to hear your experience and seeing how you can mobilize resources beyond the formal things. And it's interesting that the National Health Insurance allows for couples, for one person to use the partner's excess in insurance. So maybe it's even an incentive for people to to be married and stay together and access that. But it's at least it works out. So yeah, it's good that people are able to use that. Thanks for
you're welcome. And also, Elizabeth, if I may, as part of the, I'm very glad and happy to hear some of the issues being mentioned here. They are quite universal because they're things we are tackling on a daily basis as service providers. And some of the recommendations that have been given, I've been monitoring the chat box and also listening to the conversations. It's important to note that with the new administration, I think one of their main agenda was to go digital. And given that it's being like the policy, it's being implemented by government institutions. And from our side, KNH, you'll find that we started employing the EMR system, I think at the beginning, towards the end of last year. And right now it has really picked up in terms of data management systems. And we also have the issue with public-private partnerships. And I think this is the future, because in that association, we have a situation whereby our experience, I did this towards the end of last year, you'll find that, yes, we have private institutions with proper infrastructure to manage cancer, but now their main issue now, you see, they don't have clients because of the costs they've set up. On the other hand, we have public institutions with probably outdated technology or infrastructure, but large numbers. So coming up together to see if you can have a common ground in which institutions can benefit, really for the benefit of the patient, can be very beneficial and also influential in terms of the fight against the pandemic.
Thank you, Tom. Thank you so much for that comment. I saw a hand by Maculine. Maculine, are you still here with us?
Yes, thank you, Elizabeth. I'm here, and thank you for the presenters for the very productive presentation. I have two submissions. The first one, just touching on the aspect Robai was talking about, using data science and just increasing our evidence base as in Africa for cancer. And I really agree with that, as we all said, that it's an era of technology explosion. And there's a lot of data which is there in the institutions on cancer. Every time someone goes to the facility, they register the signs, the symptoms, and all that. So we could also consider working more with the technology gurus, those who have done a lot of who work with the informatics, so that they can use like algorithms to just look at the data itself, look at the associations, and come up with new inferences and even new feedback that can inform policy, even without even collecting new data from the field. And then also we've also had a lot of discussion on community insurance and strategies that can help even mobilize and work with the communities to manage the burden of cancer. So one of the ideas that we are having discussion as a KEPCA, even with the National Cancer Control Program, is linking hospices to the cancer centers, because cancer treatment it's an array and it's really holistic. It's a continuum of care. So one takes maybe 2 weeks in the hospital for chemotherapy, then after some time they're at home or they're managing the symptoms. So we are looking at putting in hospices and other community-based organizations which can help manage their symptoms even before they go to the next treatment at the health facility, but still link with the healthcare insurance. So for example, if someone has a wound, they can still get the consumables for wound cleaning and others from the facility, and it's paid by the health insurance as much as that intervention is done at home or outside the hospital level. So I think it's just also just being keen and looking at the opportunities and being innovative and how we can still make use of the funding areas that we have and still fit within our community and our section. Thank you.
Thank you, Magdalene, for that. I see on the chat box there are 2 comments. Not sure whether I can see the other one. Mishka, you can help me with a comment from Nigeria. I seem to have lost it.
Yes, I can see. And it's Dr. Kudus. I don't know. He says his internet is, or he has low bandwidth. Pointing out that the hidden cost contributing to financial toxicity and catastrophic spending is the cost of logistics for cancer care, especially in large countries like Nigeria, where patients are referred several kilometers to get care, which was one of the areas that was addressed both by Dr. Knues and Dr. Robai as well in their presentations. And then John Black actually has a question of, has there been success in increasing the donor base for corporate social responsibility of businesses and corporations, thinking of the success of Children's Hospital in Egypt, and he shares a link there.
Yes.
For those who might not know, it has a very interesting story of how they mobilized really millions of dollars from individuals, sending even as little as, I don't know, $1. And now it's, I think, one of the best hospitals in cancer care in the continent. So not waiting on the governments. I'm trying to, bring us to what we can do as opposed to the government. So if there has been any successes there from your mobilization of resources from individuals, from donors, you just mentioned about donors, that would be very interesting to hear about how it works.
Thank you, John Black. I see a hand raised by Sydney, and I'm sure Sydney has something to tell us about, fundraising for medical insurance. So Sydney, welcome.
Thank you, everyone. Sorry, I joined a little bit late. I was in another meeting, but I just want to reiterate some of the points that have been spoken about. For example, what Magdalene was saying about palliative care. We have a wide palliative care network in Kenya, for example, but palliative care services are the patients only discover them at, when it's time for end of life treatment. This is something that should be reintegrated from the time of diagnosis. And there's a lot of advocacy that has to be done as we're advocating for the national cancer control programs and the governments to include diagnostics and to include other things. We should also talk about palliative care. But I also want to speak from my level of experience from Hope for Cancer Kids in Kenya, where right now we are supporting about 371 children with national health insurance. And we pay for them the insurance premiums and they're able to get cancer treatment. It's very hard because a lot of our funding comes from individuals. Crack the corporate donations yet. But one thing I wanted to say is that we should start advocating also for things like syntax. You go to countries like the US and you have tobacco companies, you have alcohol companies that produce alcohol, and they have something called syntax, whereby a certain percentage of the profits they make have to be donated towards initiatives that help reduce the causes of the tobacco and the alcohol. But also on top of that, we also have to hold our own local corporates. There's a lot of money in Africa, and it's just that the local corporates have not yet tapped into the corporate social responsibility angle yet. So it's something that we have to push because there's a lot of money in Africa, but it's not being utilized in the way that it needs to be. And with cancer being one of the biggest challenges right now, I think that's the way to go. Thank you for that.
Mm-hmm. Thank you, Sydney, for the impactful ideas that you're sharing. For sure, at the Moi Teaching and Referral Hospital where I work, the Hope for Cancer Kids program has managed to enroll a number of children from Western Kenya region. And all these funds come from individuals, you know, people pull together their resources, and Sydney and his team are able to support the children. So my question is, currently we are focusing on already sick people. What about if we changed strategy and started ensuring that we enroll people into medical insurance way before they fall sick? Because this is a pool of money that is put together. And maybe, for instance, I can use $5 paid per month. And when you look at cancer treatment, it's so expensive, it's so pricey. So by the time 100 people pull together their resources to pay maybe for that one cycle of chemotherapy, no wonder the insurance funds are getting depleted nationally. Maybe we can focus on ensuring that we enroll healthy people, not only, you know, looking for people in hospitals, but going into communities now and going to churches, going to marketplaces, enrolling people into health schemes before they are sick, so that we are able to afford, you know, comprehensive care for people when they become sick. Thank you. Ching, I see your hand is raised.
Hi everyone again. So I'd just like to echo what Sydney and also yourself, what you've said about the issue of tapping into the corporate world, and just to the is it the CSR activities or to the syntax initiative. It's also important to add that for us to go through that route, you must have data. I think justification is very important, and it all starts with the numbers that you have. So the first stage will be any given institution, whatever you do, learn to manage your data and keep data. Data will inform, data will inform the decision to be made. And in terms of enrolling healthy people, I think insurance is not only for the sick. Anyone with a sustainable income, it's advisable. They do have medical insurance, and not only the government-sponsored insurance, but also the private ones, if you can, because it cuts across. The message is very clear. The disease does not discriminate, and it's very costly. So to mitigate such issues in future, I think it's important for everyone to have medical insurance. And we need to also do a bit of research into how can we make the insurance accessible to everyone, not only those that with sustainable sources of income. The government has been very resourceful, especially with the UHC Universal Health Coverage Program. At least the pilot in Kenya, they had a pilot session. I think it was about 5 years ago with the former administration. Considering the bill, the current budget that was read not so long ago has, we have some budgetary allocation for the universal health coverage. As advocates, I'd encourage everyone to keep on just following and just seeing that it's implemented in the way that it will benefit all, especially the old children, and as well those students as well, because what we are getting is that cancer affects everyone.
We've lost Tom. He's dropped out.
That's all. Yeah.
Thank you, Tom. Dr. Zippy. Dr. Zippy.
Actually, he has actually just talked what I was going to talk about. Because really the main concern, even if you're saying that everybody should be covered, I think we need a lot of sensitization to the public to understand why it's important for their health to be insured. Because despite the subsidized fee for NHIF, you'll still find that many people will not prioritize it. And yes, things are tough. Maybe food on the table is the most important thing. But if you have food on the table and you're not well, you might not be able to eat that food because you're not well. So I think our campaign should really be to the public that health is also your responsibility. I don't think there's a way that our government will very soon cover 100% of our health. That's a reality. We are seeing what's happening, especially in Kenya. So we need to sensitize people to pay for their NHIF or any insurance that they can afford. Those community insurances have helped a lot in places like India. People actually come together to contribute a certain amount of money, and when they have an illness, they're able to go into that kitty and support each other. So I think we need to sensitize our community to understand health is important, health is your responsibility. And if you're able to pay that 500, because it's going to save a life, and not just your life, but your family dependents' life as well. Thank you.
Yeah, thank you, Dr. Zippy. I think health financing is a topic that's really requires more and more time. People seem to have so much they would love to share. And I see a hand by Beryl. Beryl, please share.
Thank you, Elizabeth. I hope all of you can hear me.
We can.
Hey, my name is Beryl. I come from Faraja Cancer Support Trust. Basically, I also just wanted to share a little bit about what we do and how we help patients, especially when it comes to the financial aspect. So Faraja basically was founded in 2012 with the aim of providing emotional, practical, and healing support for anyone affected by cancer. That's both patients and their caregivers. We do this by offering free non-medical services through 5 main pillars. That is information, complementary therapies, support group, Crafts for Cure program, and the Faraja Medical Support Fund. So basically for the information, we have a library with books based on different diagnoses. We urge patients to just read them. We would lend them out to patients. Most patients who come at the center would be free to take them home. Also, we have complementary therapies. So the therapies, like I mentioned, are free of charge. Things like nutrition, counseling sessions. We have movements like Zumba, yoga, transformational breathing, and many more. We do also have support groups. So the major support groups that we have are breast cancer support group, prostate cancer, gynecological, and also caregiver support group for the caregivers. For the Crafts for Cure program, this is an art and music therapy program that runs basically at Kenyatta National Hospital, where we use therapeutic art play, and also just diversional therapy like knitting and beadwork to demystify the journey of cancer to the children, the teenagers, and also young adults within the hospital. So we also have the Faraja Medical Fund. Now that's where I wanted to talk about. The Faraja Medical Fund was founded in November 2019. And up to date, we have supported, 2016. Up to date, we have supported 661 patients at a cost of 58 million. Out of the number, we noticed that 72 of the applicants were females and 28 were males. That should also talk about who reaches out for support, majorly as the data shows, it's mostly women also. Also from the data that we have supported 146 children for the cancer treatment, the cancer active treatment. So basically that's what we do. I would also urge you guys from different aspects, from different regions within the country to keep sending patients our way for the support. Currently we have 2 centers, that's in Nairobi, and the other one is in Eldoret, just at the Chandaria Center. That's what I wanted to share with you guys today.
Thank you, Beryl. I guess health financing is big, and I'm grateful to Robai and Kunus for being the voice of sanity in the midst of an emotional discussion. Thank you, everyone, for your time. Thank you for joining the call from wherever we are. We surely would like to take this on and continue this discussion. And to you, Mishka, I don't know if we have announcements from Charlie. From me, it's a wrap. Thank you all so much. Charlie, welcome.
Well, thank you so much, Elizabeth. And I'd also want to echo our gratitude to our speakers for today, Dr. Labai and Dr. Kunus. We are very grateful for the discussion that you've initiated. And I would also like to thank our participants for today, quite active. And we are grateful for you to be able to attend and to be able to contribute to the discussion. So we are going to share this recording on Basecamp. And if you're not on Basecamp, you can reach out to us and you'll be added to our distribution list. So look out for the speaker presentations and the recording. And I'm sure we may want to refer to some of the ideas shared over there. So we are coming to an end of our Africa Cancer Echo year. So we normally run from September to August every other year. So next month will be our last session for the year. And we are going to be looking at the 5 years retrospective of the Africa Cancer Echo, where we've been, what we've been able to achieve, what we've learned, and what maybe we need to do to improve the platform. So we hope that you'll be able to join us and also come with ideas on how we can improve the platform as we continue learning. So we are very grateful for you sparing time to join us. And also just to mention, we managed to complete the evaluation survey. And we are in the process of analyzing the data, and we are going to be sharing the feedback in the course of as we continue with the analysis. And like we had mentioned, that feedback helps us to design and to learn the platform. So it informs even the topics, the kind of topics that we cover on the platform. So we are grateful for the feedback that we received, and we are going to be sharing more on that. So thank you very much, and we wish you a good time. I don't know whether Mishka, you have anything to add?
Nothing from me.
Okay. Thank you all.
Take good care, everybody.
Thank you. Bye.